So good evening, everyone. Hope you are doing well. Uh, in today's session, we are going to look at our exam lab questions, and this is the part three in the exam lab series, where I've gone through question number 36 to 50, uh, providing detailed explanation for each and every question in this regards. This is also my lecture number 89 of my lecture series. Extremely important lecture series to help preparation for your endocrinology exams as well as clinical practice. So let's start right away. So exam lab is having a total of 200 questions. These are extremely important set of questions because we have seen over the past years, both in the European board as well as the specialty exam, we encounter several questions which come from exam labs. So as I mentioned, this is my part three. So in part one, I've gone through questions 1 to 25. In my part two, I have gone through questions 26 to 35. And this particular part, I have gone through questions 36 to 50 with detailed explanation. So let's start right away. So question number 36 is a 29-year-old woman with primary infertility, having had unprotected sexual intercourse for the last 15 months, had menarche at age occurring at 13.5 years. Her menstrual cycles were irregular, occurring every 20 to 60 days. There was no history of galactorrhea. She denied any abnormal hair growth. On examination, her BMI was overweight at 28.9. She had normal secondary sexual characters and a visual field for full to confrontation. So, looking at the clinical history, we have important pointers here towards primary infertility. We have irregular cycles, which occur every 20 to 60 days, and we have high BMI in the body mass index. In terms of the investigations provided in the question stem, we have a elevated serum androstenedione, which is at 12.8. We have a low SHBG at 23. We have a higher end LH. We have slightly high serum prolactin. The HSG was done to investigate from the primary infertility, which showed patent fallopian tubes. The partner's semen analysis was normal sperm count and motility. Serum testosterone appears to be 2.4. So, with the clinical history and the biochemistry presented to us, by now most of us must have guessed the diagnosis, which is PCOS. So, what is the most appropriate first line investigation in this regards? The cabergoline, should we give the patient HCG injections, HMG injections, metformin, or orlistat? You can have a look that oral contraceptive pills are not in this options provided. So the correct choice in this case will be metformin. So the clinical pointers are there, the biochemical pointers are there, but Endocrine Society has released specific guidelines how to diagnose a patient with PCOS. These were released in 2023, and I've already made a detailed lecture on these particular guidelines in my lecture series. So the diagnostic algorithm for PCOS is essentially is important to also note that whenever we are going to make a diagnosis for PCOS, we should exclude other causes. Like we should make sure that we are checking the TSH to identify any thyroid dysfunction, check for prolactin, check for 17-hydroxyprogesterone to rule out non-classical CH, and do other hormonal tests to rule out Cushing's or other adrenal tumors. So step one is irregular cycles plus clinical hyperandrogenism. If we exclude other causes at this point, that gives us the diagnosis as per guidelines. Step two, if there is no evidence of clinical hyperandrogenism, test for biochemical hyperandrogenism. And if we excluded the other causes, again, this gives us the diagnosis. Step three is if we have only irregular cycles or only hyperandrogenism, then we should look for polycystic ovarian morphology on the ultrasound, especially in adults. So these all will give us the diagnosis of PCOS as per the guidelines. So guidelines have defined each and everything. They have defined what is the meaning of irregular cycles, what is the importance of checking total testosterone and the other androgen markers like androstenedione and dihydroepiandrosterone sulfate. We know the androstenedione mostly comes from the ovaries, and DHEAS, if elevated, look for adrenal source. So as I mentioned, uh, in terms of ovary, look for testosterone, look for androstenedione. If you're looking for DHEAS, if that's elevated, try and look for an adrenal source. Clinical hyperandrogenism wise, we should always assess and ask symptom history for acne, for female pattern hair loss, for hirsutism. Use scales like the modified Ferriman-Galway scale. A score of more than or equal to 4.4 to 6 is indicative of hirsutism. A Ludwig visual scoring is preferred for assessing the female pattern hair loss. I was mentioning about the polycystic ovarian morphology in ultrasound. What is the meaning of that? So if the follicle number is per ovary is more than or equal to 20 and or ovarian volume is more than or equal to 10 on either ovary, then that is indicative of PCOM or polycystic ovarian morphology as per the ultrasound criteria. So pharmacological treatment options for non-fertility indications for PCOS. Of course, the first line is a combined oral contraceptive pill. And in this also the guidelines suggest to use a lowest dose of estrogen to avoid any risk. A lowest dose of around 20 to 30 microgram of estrogen is what is advised. Whenever we treat the patients for hirsutism, make sure that we guide the patient that the oral contraceptive pill and the cosmetic treatment alongside is needed, and this should be carried on for at least 6 months. And no combined oral contraceptive pill preparation is superior in PCOS. These are all the things which we should keep in mind. Second line pharmacological therapies, metformin and lifestyle changes is the core, especially when we are doing an overweight, dealing with an overweight individual with a BMI of more than or equal to 25. We start them with metformin and slowly titrate up the dose. If we are going to talk about combination therapy, that combined oral contraceptive pill with metformin with lifestyle, if you were to look at the data in this regards, there is limited evidence plus limited additional benefit of combining combined oral contraceptive plus metformin versus using them alone. In adults with PCOS with a BMI of less than 30, combined oral contraceptive pills is the first line of management for the hirsutism and irregular menstrual cycles. Metformin is used for the metabolic indication. What about um combined oral contraceptive pills with anti-androgens? So they are used specifically for treating hirsutism in women with PCOS. If there is a suboptimal response after a minimum of 6 months of combined oral contraceptive pill and or cosmetic therapy, we should definitely add the patient anti-androgens. Let's move on to question number 37. Here we have a 17-year-old Caucasian girl presenting with primary amenorrhea. On examination, her BMI is 21, her body habitus is normal, and she had an appropriate breast development. There was no evidence of any hirsutism or acne. The biochemistry given shows serum estradiol, which is low at 180, serum testosterone, which is very high at 31.7 nanomole per liter. FSH, LH appears to be within the normal range. So, what is the most likely diagnosis? Is it an adrenocortical cancer? Is it androgen secreting ovarian tumor? Is it a complete androgen insensitivity syndrome? Is it ovarian hyperthyroidism? Or is it again PCOS? So, the correct answer, based on the biochemistry and the history provided here, is complete androgen insensitivity syndrome. So, this results from a mutation in the androgen receptor gene. It is inherited in an X-linked recessive fashion, repeatedly asked in exams this inheritance. So this results in a normal female external genitalia. However, the vagina is often shorter than normal and may rarely be absent. Testes are usually located in abdomen or in inguinal canal, and there is no spermatogenesis happening. This can present in childhood with inguinal testicular hernia or primary amenorrhea at puberty. Pubertal development is normal, apart from little or no pubic and axillary hair. Body habitus, general identity, and psychological development wise, they are female. So this is extremely important. And Key features include a raised LH, a normal FSH, and testosterone levels are usually raised in this regards and raised in the male range. Orchidectomy is the choice to prevent malignancy from happening. Exact timing of surgery is controversial, but is usually preferred in adolescents after attaining puberty. In phenotypically female with partial androgen insensitivity syndrome, gonadectomy may be performed before puberty to avoid virilization. Estrogen replacement therapy is needed in phenotypically females. So, two important differentials here when we are dealing with primary amenorrhea in a young woman, complete androgen insensitivity versus Mullerian agenesis. So, karyotype wise, in complete androgen insensitivity, we have 46XY, whereas in Mullerian agenesis, we have 46XX. The gonads here is testes, whereas ovaries in the Mullerian agenesis. Testosterone level is high, usually male range, but of course it's ineffective in complete androgen insensitivity syndrome. In Mullerian agenesis, testosterone levels are normal. Uterus and fallopian tube may be absent in both the case scenarios. Vagina is short and blind ending in both the case scenarios. Breast development may be normal in both the case scenarios. Pubic and axillary hair is sparse or absent in complete androgen insensitivity, whereas normal in Mullerian agenesis. So there may be associated renal and skeletal anomalies in Mullerian agenesis. So these are all the things we should keep in mind when we are looking at the two differentials for a young woman with primary amenorrhea. Question 38, we have a 45-year-old woman attending for annual follow-up for a long-standing hypoparathyroidism. This was a complication of a thyroid surgery which was done for her 5 years previously. She was asymptomatic. She was taking alpha calcidol 1 microgram daily. Her examination was unremarkable. So investigations reveal a serum creatinine at 105, serum corrected calcium, which appears normal at 2.45, whereas a 24-hour urinary calcium is elevated at 9.8 millimole. What is the most appropriate next step in management? Should we add bendroflumethiazide thiazide to reduce this from happening? Should we change alpha calcidol to calcitriol? Should we change alpha calcidol to teriparatide? Should we decrease the alpha calcidol dose? Or should we just recommend the patient to have a low calcium diet? Correct answer is decrease alpha calcidol dose. So target serum calcium should always be kept when we are treating our patients with hypoparathyroidism at the lower end of the reference range, because renal retention of calcium brought about by PTH has been lost. So thus any attempt to raise the plasma calcium into the reference range is likely to result in unacceptable hypercalciuria, as was occurring in this patient, with the risk of nephrocalcinosis and renal stones in the long term. So that's why monitoring 24-hour urinary calcium is an important tool to avoid this prolonged hypercalciuria. Vitamin D analogs such as alpha-calcidol, which has a long half-life, or calcitriol to maintain acceptable plasma calcium levels are often required in majority of the patients of hypoparathyroidism. The dose of vitamin D analogs is determined by clinical response, but usually it varies between 0.5 to 2 microgram per day. So the calcemic effect of calcitriol is 100% greater than alpha-calcidol. So in those who have swallowing problems, example radiotherapy, neck dissection, liquid preparations are available as well. So all these things to keep in mind when we are treating our patients with hypoparathyroidism. Question number 39, we have a 53-year-old man with history of sweats and tremors, found to have abnormal thyroid function test and a small diffuse goiter. He was treated with carbimazole 20 mg but developed a sore throat after 3 weeks. So if you look at his counts, hemoglobin of 15, white cell count of 2, which is on the lower side. Neutrophil count is clearly low at 0.4. TSH is still suppressed. Patient is still hyperthyroid. T4 is still elevated. Patient is clinically hyperthyroid, clinically and biochemically. And TRAb antibodies are positive. So the carbimazole was then stopped because of this neutropenia which is happening, and the sore throat resolved because, as we know, that this is one of the manifestations of neutropenia, and the full blood count then normalized. So what is the next appropriate step in the management? Should we refer the patients to early partial thyroidectomy? Should we offer the patient iodine, radioiodine therapy? Should we again restart carbimazole at a lower dose? Should we switch the patient to PTU, or should we treat the patient with glucose iodine? So the correct answer here is early radioactive iodine therapy. So agranulocytosis is potentially fatal and occur in 0.1 to 0.5% of the patients. Very important to remember this percentage. They ask this repeatedly in the exams. It is less frequent with carbimazole than with PTU, but can have occur in both these drugs, and cross reactivity is common. Hence, one drug should never be substituted for the other after this reaction has been once diagnosed. Patient typically presents with fever, sore throat, and when we do the counts, we come across the neutropenia. The other side effect which we need to keep in mind about antithyroid drugs for the PTU is the liver damage. It is 0.1% in adults, of whom 10% will develop liver failure, resulting in liver transplantation or death, which has 1 is to 10,000 incidence. Data from children suggests that the risk of drug-induced liver failure with PTU is around 1 is to 1,000 incidence. So both this is extremely important for exams, both these percentages and this incidence rate. Some cases of acute pancreatitis has also been reported with carbimazole use, and in this case, it should be stopped immediately if any acute pancreatitis occurs. And if we want to use it again in the future, this history should be considered. Rarely, an ANCA negative vasculitis can develop with propylthiouracil therapy. This may cause arthralgia, skin rash, glomerulonephritis, fever, and alveolar hemorrhage. Skin lesions can also include ulcers. The only way to diagnose this is doing a biopsy, which can show vasculitis, and the PTU should be stopped in this regards, and then steroids are indicated. Question number 50, we have a 50-year-old. Question number 40, we have 55-year-old dental nurse referred for bone densitometry after sustaining a non-displaced fracture of the femur after falling down a step. She had experienced no other fractures. Her only medical problem was long-standing anemia of unknown cause. The other family history which we have is of persistent dental abscesses affecting her father. She had 3 children who were well. She's not taking any medicine. Examination appears normal. So we have a lot of diagnostic clues here. We have a patient having a non-displaced fracture after falling down just a step. So basically a fragility fracture. She has got long-standing anemia, and she has got a family history of dental abscesses affecting her father. Looking at her biochemistry, we have a low hemoglobin. We have a corrected calcium, which is around 2.4. We have a alkaline phosphatase, which is around 56. And the important striking factor here is the DEXA scan score at the hip and the spine. They seems to be very elevated at plus 5.8 and plus 5.4 respectively. So patient with fragility fracture, anemia, but having a high DEXA score. That leads us to the diagnosis of osteopetrosis. Now, these are some of the causes of increased bone mineral density. This can be in the form of artifacts, which is like excess skeletal calcium, vertebral fracture, radiodense material, or extraskeletal calcium. Generalized increase can occur in acquired osteosclerosis like renal osteodystrophy, fluorosis, mastocytosis, myelofibrosis, or acromegaly. Focal increase in the bone can occur with Paget's and tumors. And genetically, it can be because of osteopetrosis as our patient, or it can be due to sclerosteatosis or LRP5 mutation. So these are all the things which we should keep in mind. Decreased absorption leading to osteopetrosis, and increased absorption occurring in sclerosteatosis. So overall mentioned causes of increased bone mineral density. So key supporting features for the diagnosis in our case is the high DEXA score, fragility fracture, long-standing anemia, which suggests bone marrow crowding, which occurs in osteopetrosis, family history of dental abscesses, because we see with osteopetrosis, we can lead to osteomyelitis and dental complications. And in milder forms, usually like in this case scenario, there may be no deformities. So, physical examination may be normal. X-ray typically of the long ones and skull will show us look for the bone-in-bone appearance or sclerotic bones. We have a bone-in-bone appearance or sclerotic bones. The calcium may be normal or slightly low. We may have a lowish alkaline phosphatase, possible anemia as well. Genetic testing, we have the CLCN7 mutations, which confirm our diagnosis of osteopetrosis and the autosomal dominant form. We should do fall precautions, orthopedic support, avoid secondary complications, and bone marrow function monitoring. And in severe cases, we will definitely need hematological intervention as well. So that's the end of my free view. If you like to have access to my for this full session, which has total of questions up to 50, so 36 to 50, I've covered the other 10 questions in this full section, and this will be access to my subscribers. So if you like to subscribe to my lecture series, there's only a one-time fee, and you'll get access to my existing 89 lectures plus all my forthcoming lectures lifelong. So I have a wide spread of lectures across thyroid, adrenals, pituitary, diabetes, calcium regulation, high yield lectures having all the previous exam recalls, exam lab questions, reproductive system, endocrine labs, genetic syndromes, lipid disorders, and all these guidelines are covered in my sessions. So extremely useful lecture series for your exams. Thank you so much. Keep subscribing to my channel.